Good day, everyone. I'll be presenting randomized control trial on the additive effect between calcium hydroxide and sodium hypochlorite in an intervisit root canal dressing. It was conducted by a collaborative group from India and Switzerland and was published in December 2025 in the International Endodontic Journal. This trial asks whether mixing calcium hydroxide with sodium hypochlorite for an intervisit dressing improves root canal disinfection without increasing periapical inflammation, and finds a clear additive antimicrobial effect with similar inflammatory marker levels between groups. Study objectives are to compare the proportion of canal negative for anaerobic growth after 1 week of intervisit dressing of calcium hydroxide with sodium hypochlorite versus calcium hydroxide mixed with saline, and to compare the quantitative CFU counts at each step, pre-treatment, after chemomechanical preparation, and after dressing, and to assess whether calcium hydroxide mixed with sodium hypochlorite dressing alters periapical inflammation via MMP9 total protein levels in periapical fluid. It is a single-center randomized controlled clinical superiority trial with two parallel arms. Participants were medically healthy non-pregnant adults above 18 years, each with a single-rooted tooth with pulpal necrosis and asymptomatic apical periodontitis. Participants who had systemic anti-inflammatory antibiotic use, inability to isolate with rubber dam, non-restorable teeth, or refusal of consent were excluded. Patients and microbiology lab personnel were blinded, and operator was not. In the first visit, rubber dam isolation and surface disinfection, access working length determination, and initial apical enlargement to size 20, and baseline microbiological sample was taken with sterile paper point into reduced transport medium. Canal shaping to size F3 with pro-taper universal, irrigation with 3% sodium hypochlorite with side vented needle 1 mm short of the working length. Neutralization of sodium hypochlorite with 0.5% sodium thiosulfate, then distilled water. Second microbiological sample was taken. In the test group, calcium hydroxide powder mixed with 3% sodium hypochlorite as a thin slurry placed with a lentil spiral, and in the controlled group, calcium hydroxide powder mixed with physiological saline at same ratio and placement technique, and access was sealed with cavet. After 1 week, re-isolation and disinfection, removal of the dressing, irrigation with 10% citric acid to remove calcium hydroxide, then saline, and third microbiological sample was taken. Periapical fluid sampling by extending a paper point 2 mm beyond apex for 1 minute, stored at negative 80 degrees Celsius for MMP9 total protein analysis by ELISA and Biorette total protein. Final irrigation with 3% sodium hypochlorite, then 17% EDTA. Obturation was done using AH plus sealer and gutta-percha. Final microbiological post-dressing samples was a 48 for the test group and 50 for the control group. Groups were similar at baseline for age, around 40 to 42 years, gender distribution, jaw and tooth type, incisors, canines, and premolars. At baseline, all canals had anaerobic growth. CFU counts were high and similar between groups. After chemomechanical preparation, CFUs drops significantly in both groups, but all canals still cultured positive. After 1 week dressing, 19 of 84 canals in test group had no anaerobic growth. 3 out of 50 canals in control groups had no anaerobic growth. Median CFUs were significantly lower in the test group than in the control group after 1 week. And to conclude, mixing sodium hypochlorite with calcium hydroxide for an intervisit dressing in necrotic single-rooted teeth with asymptomatic apical periodontitis significantly improved intracanal disinfection compared with calcium hydroxide mixed with saline, as shown by a higher proportion of culture-negative canals and lower CFU counts after 1 week. And the periapical inflammatory response, as measured by MMP9 total protein and periapical fluid, did not differ between sodium hypochlorite and saline slurries, suggesting that combined dressing did not provoke additional detectable inflammation. Clinically, this approach could be useful when more disinfection is desired between visits without extending chair time by exploiting the additive effect of sodium hypochlorite and calcium hydroxide. The limitation of the study are the primary endpoint is surrogate outcome. It is associated with prognosis but does not directly prove better long-term healing or clinical success. Only microbiological and biomarker outcomes at 1 week. There is no healing data or long-term clinical outcomes were reported. Culture-based methods focused on anaerobes and may miss persistent facultative gram-positive species highlighted by molecular studies, and the microbiological picture is therefore incomplete. Some procedural aspects are not standard in all practices and may affect generalizability. Operator was not blinded, and there was some loss to follow up for the final sampling, though randomization should have balanced most biases between groups. And thank you.